So today my topic is tailored surgical treatments for Moyamoya Vasculopathy. I come from Shanghai Huashan Hospital. So this is our new campus. Now totally we have 4 campuses. Last year we have 18,000 operations. Totally now we have 800 beds and 40 operating rooms. We are the WFNS and the HCNS training center. So this is a typical Moyamoya disease. According to the Suzuki stage, there's 6 stages. This is stage 1. We can see the stenosis to the distal part of the ICA and the original part of the MCA and the ACA, and very little Moyamoya vessels. This is stage 2. We can see the Moyamoya vessels originated from the M1 or A1 segment. This is stage 3. We can see more Moyamoya vessels. Stage 4, actually the Moyamoya vessels was decreased than stage 3. This is a stage 5. We can see some spontaneous stoma come from the ECA branches. Like this case, it's from the middle meningeal artery. This is stage 6. Almost all the intracranial ICA was totally occluded, but still some collateral from the ECA branch and the posterior circulation. We also have some Moyamoya syndromes like this. This is a MCA occlusion case, and we can see the perfusion was decreased a lot in the left hemisphere, and this is a Moyamoya syndrome. We also have some special Moyamoya syndromes like this. This is a Moyamoya disease combined with AVM. This is another case, Moyamoya combined with AVM. So this is the final result of this patient. I remove the AVM and do the bypass to the same session of the operation. So for Moyamoya vasculopathy, I always use the 3 branches of ECA, which is STA or postauricular artery or occipital artery of scalp, deep temporal artery of temporal muscle, and the middle meningeal artery of duro. In my more than 7,000 Moyamoya vasculopathy bypass cases, only 9 cases the surgery was unnecessary because they have already enough blood flow from the spontaneous stomas. Like this patient, the spontaneous stoma mostly come from the middle meningeal artery. And you can see this is a very abundant blood flow come back to M2 segment, and all the MCA territory was collateralized by the middle meningeal artery. For most of the late stage Moyamoya, although there's some spontaneous stoma come from ECA branch, but they still have ischemic condition or some hemorrhage, so they still need the bypass surgery. Middle meningeal artery also can be originated from ICA branches, like this patient. The MMA comes from the ophthalmic artery, but not from the ECA branches. So I always use the combined approach for Moyamoya to allow maximum use of the 3 arteries, STA, postauricular artery or occipital artery, and the middle meningeal artery and the deep temporal artery. So you can see the different result for the 3 arteries. The STA MCA bypass combined EDMS was all individualized, designed according to the ischemic condition of the patients. the skin incision, the bone flap, and duro, and the bypass location was all selected according to the preoperative DSA examination. So this is a scalp flap according to the anatomy of STA, occiput artery, or post-auricular artery, and the middle meningeal artery and the ischemic area. I never use a head clamp to protect the contralateral STA. Sometimes we also have some invalid EDAS cases from other hospitals. Sometimes direct bypass was infeasible, more likely in female patient. In my personal series, the female patients around 11% couldn't do the direct bypass. You can see on the left side, in the whole big surgical field, there's no recipient artery big enough to do the direct bypass. On the right side, we can see technically the left, this vessel was large enough to be the recipient artery, but the other branch of MCA was already totally occluded. So this is very dangerous if we do the direct bypass. It can cause the congestion of the blood flow in this very small, in this small vessel, and can cause a bleeding. The male patient's STA was normally larger than the female patient. So this is a STA for male, and this female patient, we can see the post-auricular artery substitute the parietal branch of STA. Dissecting of STA was quite fast. For female patients, only take mean around 7 minutes, and for the male patients, it takes a longer time because there's more big branches. This is a preoperative and post-operative STA flow by NOVA examination. We can see the male patients STA carry on more blood flow than females. So this is how I dissect the STA from inner side of the scalp. You use a small power monopolar to dissect the STA. It's very fast and easy way. So the mean thickness of female scalp is around 6.5 millimeter. For male, it's around 8 millimeter. The incidence of delayed scalp healing or infection is higher in female patient. Now I always close the incision of superficial temporal fissure like this. So sometimes even 2 layers suturation, and if the sometimes I also use a strip of the duro to fix the incision from inner side. So after this treatment, the delayed scalp healing or infection was never happened. So keep the integrity of STA, deep temporal artery, and the middle meningeal artery intact is very important in Moyamoya surgery. So this is a craniotomy. The bleeding loss was less than 20 milliliter. Sometimes especially in the late stage moyamoya, there's some spontaneous stoma come from the middle meningeal artery. So the best protection of middle meningeal artery is keeping the integrity of middle meningeal artery, middle meningeal vein, and the covered bone complex. So sometimes I do the double window technique. So this is a double window. Sometimes, according to the spontaneous stomach location, we also can use single bone flap combined with multiple hole or double frontal bone flaps. The dural was also individualized design according to the anatomy of the main branch under the main branches of the middle meningeal artery. So this case, in this case, we can see the spontaneous stoma come from dural to cortex. So it's protected very, very well. So this is what we can see, the middle meningeal artery and the middle MMV under the microscope. We can see it's impossible to coagulate the middle meningeal vein, but at the same time to protect the integrity of MMA. So this is my resolution. So I make a strip of gel foam to make a roll like this. So I call this roll the Chinese spring roll. You can keep the integrity of MMA at the same time getting the hemostasis of MMV. The stoma is located in ischemic area. So the anastomosing, the bypass is the most simplified anastomosing. I only use 2 or 3 curved micro temporal clips. You don't need to sacrifice any branch of the recipient arteries, and I never use additional alien materials. Interrupted suturing and square knot is enough. So this is the square knot. You can see it couldn't be loosened. But if the suture tail point to the same direction, you can see this is a slide knot. So this is dangerous. We also analyze different topographic features. This is the most common one on the surface of the plane. We can use 2 mini temporal clips to occlude the distal and the proximal part of the recipient artery and all the small branches. Sometimes it's like on the slope of the valley, we can clip the vessel in an oblique way and support the clips with a gel foam. Sometimes it's very deep in the in the valley, so we can use clips to elevate the recipient vessel. So this is makes anastomose more easier. Sometimes we also can use left a small branch to open to let some reflux of blood flow. So this can make a small pressure between the 2 layers of the recipient artery, and it's more easier to see the 2 layers of the recipient artery. Avoid stitch to the contralateral side. If you rinse the heparin saline frequently, you don't worry to form the thrombus. So this is a loop technique. the first stitch to the toe, then here, then one side, you make 5 loops and cut the loops and then make the interrupted suturing. So why I insist the interrupted suturing? Because the stoma can be enlarged. Like this result, you can see the stoma enlarged a lot, 2 or 3 times, comparing to the immediate after anastomose. So the targeted bypass means single. This is a single and double bypass, and the triple bypass distribute the blood flow into different cortex. So the Moyamoya vessels hemodynamic change is very complex. The 2 common fluid mechanical principles in bypass surgery. The first one is Poiseuille's law. This is a Poiseuille's law. So the delta P is the only motive power for driving the blood flow. We should make sure to keep the delta P positive. So the stoma near the high pressure location is dangerous for delayed occlusion of the bypass. So we should select the right position of the recipient artery. So actually we already published the 2 types pressure gradient of MCA. This is still keeps the physiological direction. So the P proximal is larger than P distal. But in Moyamoya vasculopathy, it's quite common for the second pressure gradient of MCA. It's a reversed physiological direction, which means the P proximal was less than P distal. We can see the blood flow comes from PCA to MCA. So the M2 segment, the pressure was lowest. There's also a lot of intermediate state. The direction of the flow within cortex blood vessels is complex because the compensatory blood flow comes from different vessels, different directions, and different volumes. This is after the double bypass intraoperative ICG. You can see this is a bidirection faster blood flow, which means big delta P. So this kind of condition, the bypass is sustainable. So this is a single bypass. We can see the red T, and this is a double bypass. We can see the 2 red T. But sometimes if the one arm of the T was short, it's dangerous for delay the occlusion. So this is a followed case from another neurosurgeon. You can see that P in this stoma is very positive. And the red T, one arm was very short, only 2 or 3 millimeter. So just after 1 week, you can see the bypass was almost occluded because the delta P was too small. So intraoperative Doppler, we can see the 2-direction blood flow, and almost all the successful bypass was 2-direction. Actually, adjust the injecting angle can adjust the different proportion of the blood flow. We studied the 50 cases comparing the first pressure gradient of MCA and the second pressure gradient of MCA. We use the parallel bypass and the anti-parallel bypass, which means the parallel bypass means the inflow keeps the same direction with the original flow. The anti-parallel bypass was a reversed way. So the result shows that the parallel bypass is better, which means you should keep the injecting blood flow with the same blood flow direction in the original recipient artery. So the distribution of blood flow can be partially determined by adjusting the injecting angle. And according to Poiseuille's law, Q was inversely proportional to air. So which means by adjusting the length of the donor vessel, the blood flow distribution was can be adjusted to cortex with different ischemic degrees. Like in the left side, we can see this one in the frontal lobe. The blood flow is more than on the temporal lobe. In this, in the right picture, we can see also the frontal lobe blood flow is larger than the frontal lobe. So the short and the straight donor artery can transport more blood flow than the longer and curved ones. After the bypass, actually every case, we can see the new watershed formed between the EC and the IC territory. So this is a blood flow in the artery follows the change of delta P and reforms the equal point of the pressure. So these three-dimensional equal points are connected to form a new watershed of the blood flow between ICA and ECA territory. So we can see the new watershed is a three-dimensional curved surface, and the pressure equilibrium of the ECIC is a decisive factor. The second common fluid mechanical principle is the Bernoulli's principle, which means mainly about blood flow energy loss. So this is a hemodynamic change of Moyamoya disease. This is the same story as the throat principle. We can see the flow velocity is the largest to the constricted section in this area, and the increase in the flow velocity is accompanied by a significant decrease in pressure at the constricted section. The M1 bloodstream flows through the Moyamoya vessels and into M2, similar to the flow through the restrictor when the beam expanded into a larger area. And the velocity was decreased, pressure was increased, but the downstream pressure don't fully recovered to the upstream pressure due to greater internal turbulence and the energy consumption. So this is a hemodynamic change in Moyamoya vessels. Actually, this is atherosclerotic Moyamoya syndrome. My friend, Professor Conghui Li, he put the stent into this almost occluded M1. Actually, you can see after the stenting, M1 was reopened and the M2 image was no longer delayed. The blood flow and the pressure in M1 was restored to physiological state. So the blood flow of the Moyamoya vessels is significantly reduced and are no longer visible. So actually the natural history of the Moyamoya disease was reversed as this treatment procedure. So for the Moyamoya vessels, we always worried about the anastomotic aneurysm because almost all the recipient artery was very thin. So the extra local energy loss increases the likelihood of the anastomotic aneurysm formation. So actually the energy loss varies with the shape of the stoma. Actually some neurosurgeon recommended the fish mouth anastomose, but actually according to our calculations, this kind of anastomose increase the local energy loss. So this is the calculation procedure of the zeta, the local resistant coefficient zeta of the fish mouth stoma. The greater the ratio of A3 to comparing A1 is, the greater the resistant zeta is. For example, the bigger ampular part of ICA cause additional local energy loss. So in my opinion, the stoma should keep oval shape as natural branches. You can see, you can observe all the natural branches. Actually, the shape of the stoma was oval. So we can also calculate the relationships among diameters, parameters, and the cross-sectional area of oval-shaped anastomosis. And this is the result of zeta calculation. Actually, we can see under the same condition, the ratio of A3 to A1 is closer to 1. So the local resistant coefficient zeta is smaller comparing to the fish mouth, and the local energy consumption is lower. We also can find the sharp bands quite common in STA. Suppose STA is taken from point to A to point B. If the connective tissue is cut in the sharp band to make it more straight, on the one hand, the local energy loss Hj of the band can be reduced. On the other hand, the flow can be shortened by the H, and the HF was reduced. So the next one, we can cut the connective tissue and make the band straight. So this is better for carrying the blood flow more efficiently. So in the bypass of the Moyamoya, normally the recipient artery couldn't drain all the blood flow in the donor artery, which means a cut flow in the donor artery. So the bottleneck for blood flow, how to be less wasteful, is a first question. So actually we can use I prefer to choose the stoma near the bifurcation of the recipient artery. So this kind of location can be can make the blood flow drainage into the cortex more efficiently, according to the calculation. So the second bottleneck of the blood flow, how to be less wasteful. So double barrel bypass with a parietal branch of STA, we can use one single branch to create a double bypass. But in the meantime, we still keep the frontal STA branch for more blood supply of the scalp. So this can be let the cut flow more can go into the cortex. So there's difference between donor and the recipient artery of Moyamoya. Donor artery, normally they are thick wall. The resistant index in situ was 0.7 to 0.8. The resistant index can decrease to 0.5 to 0.6 after bypass. The blood flow keep increasing after bypass. Normally in 2 weeks, they can get in the peak. Normally, the recipient artery is M4 segment. They are thin wall, and the recipient normally 0.5 to 0.6. If the network of MCA was quite good, so they can drain the blood flow to M2 segment and then redistribute the blood flow quickly along the MCA networks. But if the MCA network was quite poor, they can make the congestion of the blood flow in very limited cortex, and this kind of condition is very dangerous for bleeding and infection or edema. So this is a good MCA network. We can still see the main branches like the superior and inferior trunk of MCA clearly. So this kind of MCA network can bear more blood flow from donor artery. But we also can have some poor MCA network, especially in the late stage of Moyamoya. Like this patient, it's stage 6. So this MCA network can bear a small amount of blood flow from donor artery. And this is very dangerous for delayed bleeding. So this is a good MCA network. You can see the reflux blood flow to M2 and redistribute the blood flow along the MCA network quickly. So the condition of the recipient MCA network is the key role to determine the blood flow volume in bypass. We analyze the blood flows, use NOVA testing. STA to good MCA network, the blood flow can keep increasing after bypass. You can see the intraoperatively, it's normally around 20 to 30 or 40 millimeter per minute. But after 7 days, this bypass increased to 77 millimeter per minute. And in the double bypass, like this patient, after 7 days, it's already 130 millimeter per minute. It's almost can recover all the MCA blood flow. So this is a long-term follow-up. You can see the difference of MCA networks. On the right side, the MCA network was quite good. So the STA carry on 140 millimeter per minute. But on the left side, the MCA was quite small and a very poor network. The STA carry on only 91 millimeter per minute. So it's around 50 millimeter per minute less than the right side. So this is a good network. You can see the donor artery increased the diameter a lot. But the same patient with poor MCA network, the STA still patent, but only still very small. Feeded only limited superficial territory. So this is the diameter change of the arteries. The STA, deep temporal artery, and the middle meningeal artery. Also, the ratio of the diameter changes. We can see it increased a lot. So this is a CT perfusion change, pre-operative and comparing to post-operative. The change of CT perfusion parameters, the CBF, CBV, and the TTP. So this is a volume change in STA, deep temporal artery, and the different arteries, ECA, CCA, ICA, basilar artery. And this is a resistant index change. Intraoperative MR, we can see the bypass was patent. And this is a CBF and CBV change of intraoperative. So this is an intraoperative MRP study. We can see the immediate change of CBF and CBV. So this is a long-term blood flow change in different arteries. We can see in the bypass artery, the main trunk of STA was all increased, and the main branch of ECA, middle major artery, and deep temporal artery was all increased 2 or 3 times comparing to their preoperative blood volume. And the ICA blood flow was decreased a lot, almost half of the ICA blood volume was decreased. So the basilar artery also decreased around 20%. So we can see the blood flow was all substituted by ECA branches. So we can see not only the surgical hemisphere, but also the contralateral frontal lobe can be supplied by the ECA branches. You can see almost all the ICA blood flow was almost totally replaced by the ECA branches. This is a long-term follow-up case. We can see the STA replaced all the ICA blood flow, even to the contralateral side. So this is the take-home message. Understanding the fluid mechanic principles is key to successful Moyamoya bypass surgery. The Poiseuille's law, Bernoulli's principle, and the throat principle in Moyamoya is very important to understand the hemodynamic changes. 2 types of MCA pressure gradient. This is very helpful to redistribute the donor arteries blood flow into the cortex. The fluid mechanic formula for calculating the resistant coefficient zeta of different stoma can avoid delayed stoma aneurysm. So we also can adjust the injecting angles and the length of the donor artery to make the bypass more efficient. But for the Moyamoya bypass, there's some special consideration. The more blood flow, the better is not correct for Moyamoya. Males' STA carries more blood flow than females. The diameter ratio of the donor artery comparing to the recipient artery, if it's larger than 2.5 times, we should consider quick bypass, because according to the Poiseuille's law, the donor artery carrying on around more than 20 times blood volume than the recipient artery. So this is very dangerous for bleeding. Conditions of MCA network is a key rule to determine the blood flow volume in bypass. So if the STA was quite thin and the good MCA network were very good, so we can consider the multiple barrel bypass. So this is after 10 cases bypass, and we still have time to have a dinner. This is a live case in India. So this is my personal experience in bypass. Last year, I have 1,039 cases. Now totally I have more than 7,000 bypass in 110 hospitals in China and India. We are still learning every day. You can see how complex of the hemodynamic change can be seen in the flow 800 ICG. You can see the turbulence in the vein, and some blood flow was almost stopped in some segment of the vein. And the circulation time from artery to vein is shortened a lot in the surrounding the bypass location. So the actual hemodynamic changes are very complex, and when combined with Poiseuille's law and the Bernoulli's principle, the local rapid blood flow creates turbulence, and the pressure changes are also complex. So the local slowing of the venous blood flow is due to the small delta P. So we are still learning every day. Thank you. So we can see last year, we just published this book. It's edited by Peter Jokosi, and I also write a chapter for the late stage Moyamoya in this book. Thank you.
Okay, Sam.
Okay, thank you, dear Professor Ben, for this great lecture. And now, Professor Goel, Professor Marcus, and Professor Boba will manage discussion. And after this, I will take 5 minutes to continue my lecture about Owens. Thank you.
Dr. Bin, can I ask you a question?
Yes, please.
I want to know, you have got world's largest experience, 7,000 cases, world's largest experience, and you are a very young man. So by the time you retire, you will have 1 million cases. And you can teach the whole world how to do Moyamoya and other bypasses. And you have to, I want to know, in your 7,000 cases, how many cases you failed, or you had complication, or you were not happy? How many cases? I want to know from you.
Actually, for the aneurysm bypass.
Not aneurysm, Moyamoya.
Moyamoya around 20 cases. Yeah, I was frustrated.
Why? What happened?
Because the delayed breathing, or some big sometimes even contralateral infarction. So because the Moyamoya normally it's bilateral hemisphere was have some ischemic conditions. So when you did the first time, the contralateral hemisphere was also have the general anesthesia procedure. So this is a very dangerous for some of them. So some patients, they can't even tolerate a general anesthesia.
Another question.
So they can cause a big infarction.
Another small question, same line. Like in your very big experience, how many times you were not able to complete the bypass, like the MCA branch was very thin, or MCA branch was not very strong, or you could not do the bypass? Did it happen any time in your 7,000 cases?
No, never happened. Technically, I never had failed. Which means when I begin to do the bypass, I never failed. But sometimes I already introduced that in some cases, I will quit the direct bypass because there's no recipient arteries, and sometimes there's a very dangerous anatomic change, like some branch of the MCA was already occluded, and you can see there's no blood flow in it, and sometimes some branch of the MCA was still open, but there's very low flow. So this is a very dangerous condition. They couldn't bear the cut flow of the donor artery.
What do you think is the role of indirect bypass? Muscle, introduction of muscle and all those things.
It's quite useful because, especially in the typical Moyamoya disease patients. But for Moyamoya syndrome, mostly the direct bypass is more useful than the indirect ones.
So do you like to have both, like you have done bypass and you are not 100% satisfied, so you also put the muscle? Do you do like that? No.
Yes, I always do the combined approach.
Combined.
Almost
okay.
in more than 95%.
Okay.
The combined approach. Yeah.
Jack, you're there?
I'm here. I'm waiting for your very intelligent questions to finish, then I'll ask him mine now.
Yes, you go ahead, Jack.
Ben, always pleasure to hear your not only your technical issues, but of course your thoughtful approach to it. So from listening to how you do it, and I've of course heard you before, it would appear then that there must be an optimum time to bypass a Moyamoya, because if we wait too late, then the cerebrovascular resistance is too high in the late Suzuki stages.
Yes.
And if we do it too early, there is probably not high demand. So can you factor in this conversation in addition to the other physiologic principles that you discussed for us?
Because, Jack, the patient come to me, always they have symptoms. Normally they already have around 45%, they already have hematologic history. And the others, they also have TIA or some small infections, even big infections. So almost all the cases come to me is symptomatic.
So do you never do quote unquote prophylactic bypass of the other side based on physiologic demand, on an asymptomatic contralateral hemisphere?
Yes. We always do the angiogram after half a year. After the first operation. Sometimes it's interesting because sometimes, just like the slides I show you, that sometimes even you do the single hemisphere reconstructive surgery, the contralateral blood flow was also increased. So for this kind of condition, we just wait and observe.
Right.
Yeah. As you know very well, the geometry of fish mouthing, if you fish mouth by the amount of the diameter, that increases the cross-sectional area by 4 times. So yeah.
So the argument that you should use interrupted, I agree with you. I use interrupted for very small vessels, but to be honest, running, if you do fish mouth, the bottleneck isn't the anastomosis, is the rest of the donor vessel, which is 4 times less cross-section than the anastomosis site. So there is plenty of room for the STA to grow to even reach the caliber of the anastomosis. You know what I'm saying? It's
yes, because this is for the Moyamoya anastomos because for the big arteries, it's not a big issue because the vessel wall is thick enough to resist the local energy loss for this fish mouth caused.
Right.
But for the very thin wall Moyamoya vessels, normally the donor artery was much bigger than the recipient artery. We have to consider this aspect.
So when you have that discrepancy between donor and recipient caliber,
Mm-hmm.
so you have, of course, two opposing needs. One need is, as you said, to come in at an angle with the anastomosis, but that would mean larger, even more discrepancy because you have to cut at an oblique versus coming 90 degree.
Yes.
Which one do you go for? Do you go the 90 degree anastomosis to save to make it less discrepant, or do you follow the other principle of parallel flow?
Yes, you have to consider the caliber of the recipient artery, and the 90 degree makes even cut of the donor artery. So
Right.
this can save the length of the circulum of the donor artery. So this is makes the stoma more stable, and actually the distribution of the blood flow was more even into the two sides. Yeah.
I think, you know what, Jack, we'll have to, Dr. Sameh is asking for closure of this session from Dr. Bin Zhu. So Bin, very fantastic. You are absolutely fantastic. Your work is now recognized all over the world, and you are helping so many patients with all kinds of diseases, particularly Moyamoya and other aneurysms and all. I wish you very best, and I send you my very fantastic best wishes. There is one hand that is being raised. Yeah, please go ahead.
Yes,
you.
I have just two short questions, please. They are all technical. Actually, maybe I don't have the time to salute Dr. Ben because it's really excellent lectures. Now, my question, when we have in advanced cases of Moyamoya, the very weak and short and narrow vessels, is it possible to use the narrow branches of the superficial temporal artery or the occipital artery instead of using the main trunks? In doing so, we will not increase the flow to the dangerous areas and cause bleeding or overflow on these cases. This is my first question. Second is, well, maybe you can answer the first one, just not to confuse things.
You mean, actually, you can adjust the blood flow you want according to the preoperative analysis and the intraoperative findings of the MCA network. Just as I mentioned, if the MCA network was quite integrate, and you can make the one barrel or double barrel, even triple barrel bypass. But if the donor artery is much bigger, if it's larger than 2.5 times than the recipient artery, you have to quit the direct bypass because it's too dangerous. Because the MCA network was couldn't bear the blood flow in the donor artery.
So I can take a small branch from the main superficials instead of the main trunk, isn't it?
Yes,
Are you doing that?
We can use some small branch of the STA to make the blood flow. Yeah.
Okay. My second question, please, with a small comment. Why you don't like the continuous suture for the anastomosis? Thank you.
I never use continuous suturing. I only use interrupted suturing because, you know, for the aneurysm bypass, normally both the donor artery and the recipient artery, the vessel wall was quite thick. So this kind of condition, you can use continuous suturing. But for the Moyamoya vessels, normally the donor artery, the thickness of the donor artery was maybe 4 times comparing to the recipient artery. So this kind of condition, the interrupted one, you don't need to pay attention to the navel suture, the tension between the navel knot. But if you use continuous suturing, the very thin wall of the recipient artery can make leaks. So it's very difficult to treat.
Okay, very good, Dr. Ben. Thank you. And